So welcome to the Implant Therapy for Edentulous Patient, a review of the latest workflow and treatment options. It is a webinar being presented by the very own Jimmy Stigall, National Procedural Solutions Specialist for Dentistry Sarona. And we will begin the webinar shortly. And now it is my pleasure to recognize and introduce my boss, Lisa Wilsoko, Director of the NDX Education Center. Please feel free to chat with her, reach out with any questions or comments, and she's going to take it away from here.
Wow, thank you, Jessica. You know, we take for granted all those things you let everybody know, but if anybody has any questions, make sure that you reach out to us. But it's really my pleasure to introduce Jimmy, somebody that I've known for a long time. Jimmy's a seasoned dental labs operation and management executive with more than 40+ years of teaching and clinical experience in the US as well as in Canada. He's also a published author and has assisted in research projects with dentists, universities, and manufacturers. After a successful 30+ year career helping to build and lead a large dental lab in South Carolina, Jimmy served as a division president of a large dental lab network, and he's now a national procedural solutions specialist for Dentistry Sarona. As a key opinion leader, teacher, and trainer, Jimmy has demonstrated history of bringing results-oriented strategies and techniques to dental practices and labs throughout the US. And it is really my pleasure to know Jimmy. So I'm gonna let you take it over, Jimmy, and I look forward to listening to you this evening.
Thanks, ladies. Y'all gotten good at this. So thanks for having me again. Tonight, we're tasked with talking about the options for edentulous patients when we're looking at them as implant patients. And we're not going to take in a 1-hour webinar, we're not going to have the ability to take a deep dive into the all-on-4 type cases and some of the other things. My goal is to give you some possible solutions to maybe some cases where you're kind of painted in a corner, because that's what happened in my career. We did a lot of implant cases together, and I just want to make sure that you guys know all that I know, as little as it is, as we start thinking about how we can treat these patients. In order for the CE credits to qualify, you need to know a couple of things. Number one, I am a paid employee of Dentistry Sarona, and this is a CE event that is actually put on by National Dentex, and we can get legal now, so we're good to go. So, when we look at dentures on implants or removable cases or fixed cases on implants, we have to, get an idea of where we are. So, let's look at trends and current technology, current state of the art, and how, we're looking at things in the denture world. And looking at these pictures, you see a computer generated denture and a real denture, and that's a perfect example of CAD/CAM, right? CAD, computer-aided design, and CAM, computer-aided manufacturing. It's easily translated over into implant cases as well. So it behooves us to take a quick peek at, get an idea of where we kind of are in this world today. You will still see in a lot of labs and a lot of dental offices articulators and wax and carded teeth and metal partials, but unbelievably rapidly growing trend is this digital denture space, and as it is with the implants. And when we can take something and digitize it, it makes it more consistent, more predictable, more repeatable, which results in a better result for our patients. And so when we think about dentures in general, right, and one of the questions I ask in my denture program is what is your favorite thing about doing dentures? And without a doubt, the number one answer across the country is nothing. Most people don't enjoy doing these things because they're hard. And this is the hard part of it, right? The impressions and bites. That's the biggest challenge when you need to communicate that kind of data to the lab. And we've never really had an easy way to do that. The custom trays and border moldings and wax rims are certainly the standard of care, but they're not an easy task to facilitate. So, we did over 100 dentures a day at my place, and I assisted in a lot of chairside appointments, and I saw firsthand what, the doctor and assistant goes through as well as the patient. But unfortunately, that's still kind of the standard of care for record taking. Now, the good news is to do a digital denture today, you don't have to learn anything new. If you are happy with your record taking and your bite taking, you can continue to do exactly what you've done. But the folks at NDX, the labs, they have the capability of digitizing those records. So they can take your impressions, they can take your bites, they can take your models, and they will put them in the lab scanner and digitize them. And from that point forward, it becomes a digital workflow. And there's all kinds of options. And again, especially in the implants. But what we all would like to be able to say is, can I get a scan, or can I get an intraoral scan, or like the iTero or the Trios or the Prime Scan, and wave it around on an edentulous ridge and send that to the lab to get my cases done. And as you can see in these pictures, it's doable, right? That is a scan was really done intraorally, and it looks like a really good scan, a lot of good data, all the data the lab would need. But what I'm not telling you is that scan is probably the most difficult, most challenging scan to accomplish, even with the best of technologies. Even though they are accurate enough to do it, it is a very difficult challenge to get that scan done. So having the technology is one thing, right? And having the ability to use something like this to scan a full arch, either edentulous or with implant scan post or whatever, it's a great deal. So what you see folks doing today is this is some visual representation of the reference denture workflow, where we take the patient's existing denture and we scan an impression wash that we've taken in that denture, and then the bite between the two dentures. And those scans are what the lab can use to move to the next step. This is quite often the first step or the second step with an implant case, right? So if there's implants placed, we really would like to do this step prior to that so that we can use this data to help us get the implants in the right spot, but it can be done after the fact as well. Digital dentures have come a long way, and it's nice to know today that you can get a denture that's better fitting than any denture you've ever done. It certainly cuts the appointments times, and it's pretty easy to do. Labs have been doing digital dentures for quite some time, over 10 years, but they've been mostly milled dentures. And so what milled dentures are, this is a pre-processed acrylic puck, a PMMA puck. The same acrylic we've always used, it's just pre-processed. So what we have here is something that's already completely polymerized. So there's no more shrinkage, no more monomer release. And of course, it's a known entity, it's acrylic. But we're going to use a computer to replicate a design we've done, and then maybe we're going to pick up locators with it, right? I'll show you a case like that later. But it results in a denture that's better than what we've been doing with traditional methods because, again, no more shrinkage. But it's a slow process. Labs will typically charge more for this because it takes longer and the materials cost more. So, one denture takes maybe 2.5 to 4.5 hours to mill. So that's not really repeatable, and it's not sustainable or scalable. Everybody knew that we would be printing things one day, and that's pretty much has taken over. We're printing everything now, including dentures. The first step into our printed denture world was what we call Generation 1 materials. We had 3D printers, but we started getting some of the first denture color materials available to us, and we began to print these bases, print these teeth, bond the two together, and we had a CAD/CAM created denture. The big win was it was less expensive, it was faster, so we could scale it up. But we didn't have in the beginning with these Generation 1 materials the aesthetics and the strength that we needed. So this became sort of a temporary transitional appliance. Some of the Gen 1 materials are still being used for that, and that's fine. But what we need is a denture that's CAD/CAM created, printed, that's stronger than what we have. And we do have that now with the Gen 2 materials. And it's nice to be able to say, the labs can now design a denture, print a denture, and put it in your hand, and it's better than the denture you got before with acrylics. So when we move that thought process into the digital space, right, it becomes just, okay, how do we get the data translated? So in a case like this, where clearly we're going to make a set of dentures, and clearly we took conventional records, we used a little bit of a unique device called the UTS CAD, but we're going to do what we've always done as far as data capture with tissue impressions and bites and some Gothic art tracings. But the bottom picture show we're starting to digitize it, right? We take that data and we digitize it. And once it's digitized, then the lab has the ability to create that denture in the virtual world and then print that out with a pretty good resin and a pretty good printer. And so we can print them monolithically so that we can have a treatment or a transitional denture and make adjustments on that and then go to the final from that data. all in all, we have a process that's, 95% digital, and the data is better. So fewer try-ins, better fits, and of course, with the new materials, we've got a lot higher strength. Now, I teach a class called the 3-appointment digital denture, and that's not why we're here tonight, but just to give you a review of how some of this is going and how we may translate that into the implant world. This is what we all learned in the denture realm, right? 5 appointments, we get a denture made. In the real world, that doesn't happen very often. It typically takes a few more appointments because of the bites and try-ins and things. So what we look at digital is maybe it can replace some things, or maybe we can compress some things and make this go faster. And, just show you briefly how this works with the reference denture, right? So here's a case, patient's existing denture. We're going to use that existing denture as a preliminary impression tray. So we're going to take an impression wash using a heavy bodied, light bodied. We're going to do some functional impression movements or border molding movements with the patient. And when we're done, we have a set of dentures with impression material and a bite between them. That can go to the lab, and the lab can digitize that. But those of you that have intraoral scanners, right, those can go right beside the chair, and we pick up our wands and we scan that right beside the patient. And then we clean out the impression material and give the patient their dentures back. So it's a little more efficient, a little better for the patient. And today's scanners are super accurate at scanning impression material. So it's a faster process, easier process. And the result is, we get a denture done in a whole lot quicker step. Now, there's some videos out there. That was just a quick shot of a video that's available. More, if you have more information about that, just reach out. So once a dentist has scanned a patient's dentures with impression materials, they send that file to the lab, and the lab now can digitize that using the software, and the lab software actually inverts the impression into a model and orients it into the proper position. Now, that's great. Now we have our bite. Now we have our tissue surface, but we also have the purple data is the patient's existing denture. We also have the tooth data as it exists in the mouth. So occlusal plane, midline, and incisal edge, all that information is there. So there was a preliminary question that came in the email about this webinar. It's about, how can you communicate to the lab, for like a final implant case or a transitional restoration for an implant case. Well, here's a great method, right? We take existing dentures, right? We take an impression wash in them, we take a bite with them, and we scan them with our wands, and we send that file to the lab and say, hey, this is a preliminary, but the patient's tooth position is pretty good. Maybe we need to open the bite, those kind of things. But the lab then has guidelines they've never had before about where teeth are, occlusal plane, canting, all those things. And so the lab can proceed with the design and, again, print something. And for example, maybe it's a monolithic try-in, which, it's easy. The lab doesn't have to bond any teeth in or anything. The loose stone material comes in 6 shades, but, it's a monolithic version of the denture design that the lab guy does. And it can go in the mouth with implants. I like to capture a couple of the implants with some cylinders, right? So I would screw them down in the mouth and then make the changes. If we've got to adjust the bite, we adjust the bite. Communicate those changes back to the lab, and that can actually become your final impression and bite rim, because we can use those printed try-ins as a way to take another impression wash if we need it, or another bite if we need it. All that data goes back to the lab, the changes are made, and the final restoration is done. So that's kind of the workflow of the 3-appointment traditional denture. And, it's a pretty simple process. Now, we're going to go into the implant things and talk about how this would work there, but you could start plugging in almost mentally how easy it would be that if this was an implant case, how we could take advantage of some of these steps in this workflow. So there's all sorts of things being done with digital dentures and digital denture materials. And, we're here to talk about the implants tonight. So we are going to talk about it. Immediates and implants are also a big part of implant restoration. And again, with digital, when you can scan the patient's arch with the teeth that are coming out, that's data that can be sent to the lab as well. And so when the lab gets that data, then they will use a tool called a virtual extraction tool, and those teeth will come out, but they'll really still be there, right? All the lab has to do is click a button and turn them on or off. So we virtually extract the teeth. We can now have the bone reduction we want, and we can see where maybe the implants were planned to be. We can design the denture around that, and then print that final and send it out for that temporary provisional restoration. Copy dentures is another tool that I use quite often with implant cases because, again, if we do a wax up or we make a temporary and we get it adjusted exactly like we like it, well, there's a tool in the lab software that allows us to make an exact replica of that. So we can take that, take an impression wash in it if need be, adjust it, whatever, and scan it and send it to the lab and say, hey, make the final exactly like this. And the copy denture tool helps us do that. So there's some things to learn about how you're scanning dentures when you're doing regular dentures or implant dentures that, again, we're not going to get into the details of that. But you can see what the lab guy has at his disposal now, right? So imagine, a traditional denture is on an articulator and we tap it and we see some occlusion and, we take the burr and we grind it down. But in the virtual world, right, you can't always do that because of the material or the technique. But again, there's tools. Like this is a tool that I can use to print alongside the denture that I make. And the high spots are indicated by those holes you see in the occlusal bite aligner. So I print the denture, snap this thing on top of the teeth, and then spray it and grind down the high spots. So sort of a computerized occlusal equilibration without ever having to remount the dentures. And then, labs have all sorts of options. So when you get into making dentures, you got to have room, right? And so sometimes you have to design teeth. Sometimes we want to mill teeth. Sometimes we want to print teeth. Everything is optional, right? So it's nice to have the options to do that. But absolutely, when I learned about the digital dentures and saw how strong it was, I started thinking about all the Locator cases that had broken. Since then, we're now looking at all-on-4 conversions and, in NDX's in-sequence division. They actually use the loose tone digital print for all their conversion dentures that go out with every case. So with this material, with this workflow, we really have some cool options as we start looking into, okay, what is the final restoration for this patient going to look like? So let's talk about that, right? So I'm a firm believer in having options, right? I've never been one to say that an all-on-X is the best way to restore an edentulous arch, right? It's not for everybody. But I'm also not the guy to say that a locator is better for everybody because it's more affordable. I think it's great to have the options, and we need those options, right? So if you have an edentulous case and the patient's in the chair, right, having the options, gives you the tools necessary. Right. You certainly, on the previous slide, that was a good looking ridge. You certainly could make a traditional denture. There's nothing that says you absolutely have to put an implant in there. But if the patient is specifically asking about implants, now you have options there. When you see the term overdenture from me, I'm talking about a denture that is implant retained, but typically tissue supported. So we're talking about our Locator cases. Fixed is, of course, your all-on-X type, something that's actually bolted in, screwed in. It's going to stay in unless you take it out. And then the last one is something you may not be aware of, but it is an excellent option for those other type cases. And it is a fixed but yet removable appliance. And we'll talk about that one. So one at a time, full arch removable, Locator type cases. This is where we've got something screwed into the implant. It may or may not be connected by a bar. It may be screwed directly into the implant. It may be 2, 4, 6. And then we're going to put some sort of retentive element inside the denture, and these will snap on and off by the patient, right? Full arch removable. Again, these are implant retained and tissue supported. Right. So this is not an implant supported appliance. So that means the denture is going to move around a lot. So all these attachments that you see, they're typically resilient attachments that either pivot or move around, whatever they clip to. If you go over to the other end of the spectrum, right, the full arch fixed, or what, you hear all-on-4, all-on-X. This is where you have 4, 5, 6 implants that are in the bone. Some may be angled, and then we're going to bolt some type of appliance to the top of that. And there are various ways to restore that. It could be a bar wrapped in acrylic with denture teeth. It could be a monolithic zirconia that's got pink porcelain on it. It could be a titanium with porcelain applied to it. there's the options are out there. The most common being the zirconia and the hybrid acrylic around a metal bar. But other than that, the all-on-X appliances are pretty much the same. It's a screwed-in appliance to 4 or 6 implants. This is the one that you may not have heard a lot about. It's been out for a while, but it's been relatively quiet in the market. This is the full arch fixed removal, and really it brings the best of both worlds. This is both a fixed and a removable appliance. Fixed in that the appliance, like the all-on-X, fully rides on the implants. It is an implant-borne appliance, but it is an implant-borne appliance that the patient can remove. So there are various reasons for that, which we'll talk about. So those are kind of our options. So how do you decide? What do I do? And, number one call, get at the lab is, okay, this patient's in a chair. This is a situation. What should we do? When I'm chairside and assisting, I'm always, trying to chat it up with the patient about, what it is that you have now that you don't like, right? What is your situation like? What are you unhappy with? And you'll hear all sorts of things, right? Like, I'm really just tired of taking my teeth out at night. I really like to have real teeth again. And so that leads us to have the conversation with them about, a fixed appliance, an all-on-4, all-on-X type appliance. But we all know that if it's not the first or second question, it's certainly the third is, how much does it cost and what's the insurance pay? So that has a part of the decision-making process. And then, of course, we have to look at it clinically, right? Can we get the implants where we need them, where we want them to do what we want to do? And can we get the number of implants? This case is a pretty good example of, what we thought was best turned out to be not. This is a lady who was all about the fixed aspect. Money wasn't an issue, bone wasn't an issue. Going through the surgeries was not an issue to her. So that's what this is. This is an all-on-X appliance that, if you look at it here, it looks good, right? Everything looks pretty normal. Bite looks good. The buccal cord or smile line, everything was okay. But within a month or so, she was back in the practice and said, she really was having a tough time and was unhappy. Could anything be done? And what was happening is that when she smiled any bigger than this is a relaxed smile, but she smiled any bigger than this, her upper lip would get caught between her appliance and her ridge. And it's just due to her anatomy and the design of the appliance, but she had to physically reach up and pull her lip back down over her teeth. And that was, frustrating her, and understandably so. The easy answer, if you just look at this from a logistically way, is that, we add more acrylic up there to try to prevent that from going. But if I add any more acrylic up there, she's going to have a really hard time cleaning it. And so that becomes a challenge, right? So we have to think about these things, not only, money, bone, are they okay with the treatment plan, but can they clean it, right? That's always a big question to me. How's their dexterity and will they clean it? So as we're working through this with the patients, we're going to have these kind of conversations. We're going to make an evaluation of, their ability, their willingness to do what's necessary. But we're also got to look at the anatomy and say, hey, can we do a fixed appliance where, there is no ridge lap, there is no lip support, right, above the restoration because of cleansability. So all these things are questions that we think and we look and we talk to the patients about, and we try to get to where everybody's happy with what the restoration is. If we're going to do a implant-borne appliance, all-on-4 fixed bridge or the fixed removable, we always have to keep in mind about AP width when we talk about occlusion. When you want posterior occlusion, you've got to know where your implants are going to be. And so AP spread simply means this. We draw a line between the two most anterior implants and then another line between the two most posterior implants. And we measure the distance between those lines, right? That's the AP spread. 1.5 times that number is the maximum distance that you can go distally of the posterior implants. So if you want second molar occlusion in a fixed implant case, you need to plan accordingly with the implant placement, right? Sometimes AP spread limits us to first molar only, or maybe even 1 molar instead of 2 bicuspids because of the spread. So always keep that in mind when you're working about your implant placement or working with your surgeon for that. The more common problem that we have in edentulous implant restorations is the vertical space. Always has been. I think it always will be, because typically these patients are in a situation for a reason, and overclosed and bone loss is a real thing. So we have to look at this space. So one of the ways that I always looked at vertical was I looked at the ridge we were restoring, right? And I looked at the occlusal plane, wherever that was going to be, based on the bite you guys took, or any restorations existing, opposing dentition, dentures, whatever. And I want to know how much room between the restoring ridge and the resulting occlusion do we have. 15 millimeters is a goal we should all strive for, right? If you can get that, you're going to have a much better life with your implant cases. And so I ask folks all the time, if I've got that 15 millimeters, which of these restorations do you think we can do, right? A bar hybrid, right? A bar with acrylic around it. A conus case, right, which is the fixed removable, locators, or a straight crown and bridge. With 15 millimeters rule, the answer is simple. I can do anything in there that you might want to do. 15 millimeters is plenty of room for just about every restoration type that we might want to do out there today. So unfortunately, that's not common, right? 12 is probably more common. And when we get down to 12 millimeters, we've pretty much eliminated the bar type cases or the hybrid type cases. We were looking at locators or conus cases or straight crown and bridge. And I can tell you, most of the lab folks will tell you, 12 is not, super common either. It's usually somewhere in this 9 to 11. And, we're trying to do things in this 9 to 11 vertical that we really shouldn't be, right? Because in 9 to 11 millimeters, we really can only get away with locators and some crown and bridge. And if we try to expand that, then you're going to see fractures. You're going to see more recalls because things are breaking. If we get less than 9 millimeters, there's really not much we can do except maybe some anesthetic crown and bridge. So, plan your cases accordingly. Think about, how much vertical you got and how much you can get. And, again, with implant placement, while the surgeon's in there, if there's bone reduction that can be done, let's do it then. So those are our options, right? And let's go through them one at a time. So with overdentures, right? And this is the common, most widely used implant edentulous restoration is a locator case. Why is that? It's because it works, right? Locator is proven, requires minimal space, multiple options of retention, has some forgiveness with divergence with the implant placement, easy for the patients, inexpensive to maintain, and you can even do it in an existing denture. So it's the lowest cost entry, but it's also one of the better ones because it has enjoyed great success. Locators are easy. There are other brands out there, guys. That Locators is the guy that started it, but there are others like Locators out there, and they're all kind of the same. You have an abutment with retentive elements, and you have a nylon cap that snaps onto that, and that is typically surrounded by a metal housing, which makes it easy to replace the nylon cap. Again, Locators have been around the longest, and they're the most proven. There's a new version of Locator called Locator RTX, a little bit more retentive elements. They anodized it to make it a little bit more static. And they brought out this new scan cap, which is a cool tool to use that when the lab scanning the locators in the lab, they can snap that on and scan it, and it will create the ideal space in the denture when you're designing that denture digitally. So I love the scan caps. I could use these, with you intraorally as well. Right? If you got a couple of locators already placed, abutments already placed, and you can snap these on and scan them and capture the soft tissue as best you can to get the initial denture done. But you're probably going to need to do a reline in it later because, again, the soft tissue is so hard to scan. A cool thing about locators is that most people are used to doing them now and supporting them. So instead of using the locator tool that you always had to use to be able to tighten our torque locators in, most every torque wrench made out there now has a locator tool. So we can go direct to locator with our torque wrenches and not have to worry about that little secondary piece to be able to torque those in. And I get this question a lot, what torque do I put locators to? And that's not a locator question, that's an implant question, right? It depends on the implant you're placing it in as to what torquage they go in. What materials do we use to pick up the metal housings in locators? The chair side from Zest and the quick up from Voco have been the most common forever. Everybody they're both light cured. They don't generate any heat, no monomer. And so they're just fast, easy, quick. Now, when we move up to the next step, right? Or the top step, the fixed step, when all on 4, all on X, again, you're looking at 3 different appliances there, right? Titanium covered with pink composite and zirconia crowns, or solid zirconia stained pink, or a bar submerged in acrylic with denture teeth. All good options, and it's entirely preferential. You're going to get those implants placed. You're going to put some sort of abutment top on those implants, and you're going to bolt that appliance to that. Some appliances will actually bolt directly to the implants, right? But I like the abutments because they correct a lot of angles and they give us all the support we need. And again, all on 4 is a term coined by the Nobel Biocare Company, but everybody else has a version of it. And we don't say all on X to ignore what Nobel's done. God bless them for bringing this to us. But all on X was brought into terminology because all on 3 don't work. And so people have been placing an extra implant or 2 just in case we have a failure. So if you do 4 and 1 fails, you really have no option. So, but whether it's Nobels or Straumann's or Dentsply implants, whatever, the workflow is the same, right? It can be 1 or 2 stage. Those implants are going to be splinted together by the restoration, immediate loaded quite often, right? But it's 4 or more implants, and it's nice to have this temporary restoration that's fixed, because we can let the patient get comfortable, we can let the healing occur, but we can also adapt that temporary as we go so that the final's even more dialed in, right? And so they all work the same way, right? Now, one of the things that I was naive about in the beginning was all on 4 restorations, all on X restorations are pretty involved as far as treatments, right? Surgeries and time and healing and expensive. And I just assumed that patients would take care of them, right? I thought, yeah, proxy brushes and super floss, that they're going to keep it clean. So in the beginning, a lot of us built our all on X restorations with anatomy and festooning and contouring to try to make them look better. But we soon learned very quickly that that's not the case, and patient care is not what we want it to be. And things started going south in there. So we pretty much decided at some point that these restorations need to be convex on the tissue side, whatever that restoration may be. And this is why, right? You can't put a flange on an all on X because it can't be cleaned. I mean, it could be, but it'd take a lot of effort. So, we had cases like this that you take them off and you realize, okay, now I understand why everything's smelling so bad and the patient's not comfortable. And, we just can't do that. We can't put those flanges. So here's our lady from before. We didn't have a flange here for a reason, but in actuality, she needed a flange to help support her lip. Now, bars with acrylics and denture teeth had its issues, right? And we made those were our first appliances. And when we made those, a tooth would pop off or the acrylic would break. And so everything's got to come out, go back to the lab, and got to be fixed. At some point along the line, zirconia started making its way into this restorative space. And, that really changed a lot, right? No acrylic to break off here. But when you do it in zirconia, you have a few options today. In the beginning, we made these all as monolithic pieces. So really, really big pieces of zirconia, which are a challenge to build, right? It's a very time consuming, very cautious process of how to get that thing. Designing it, milling it is the easy part, but getting it baked is the hard part, because it's such a large piece of zirconia. We have to, plan for shrinkage and plan for distortion and make sure we support it accurately. And so some labs moved away from a monolithic piece, right? Because if you do a monolithic piece and again, things go south, then guess what? The whole thing's got to come out. But go to a separate where you've got a substructure and then zirconia or, porcelain crowns on top of that, that gives you some options of what only may need to come off instead of taking everything off. We've moved into another level of other materials, these PEEK or Pecton type materials. These are super high grade NASA type resins that are unbelievably strong, but also unbelievably light and take a long time to mill because they're so dense. But labs are taking this material and milling out these frameworks and, bonding teeth or bonding composite to it. And we have now a lighter weight version as opposed to the heavy titanium bar with acrylic or the heavy zirconia piece. And then the bottom one would be a titanium framework with pink porcelain and then zirconia bridges. This is a case that I did that was entirely because the patient had broken everything else we'd tried. It was time to go to the maximum strength thing to prevent the occlusion from keep fracturing the stuff we were making. So here's where I had an aha moment. And, I was doing a ton of locators. I was doing a lot of all on X, and that was great. We're clipping along good. But quite often, right, I'd get called in for a consult and, the patient, for example, locators, right? That's perfect for the 85-year-old grandmother that says, I really don't mind my denture. I just wish it stayed in better, right? It's a perfect locator case. I'm not even going to think about an all on X conversation with her. But the grandmother that says, I really would like to have teeth again, then of course we're going to have the all on X. But if we look down and we see bone loss or we see we need lip support, oh God, we can't do that. And so, she might say, well, what else you got? And I said, well, I go back to a locator. That's pretty much it. We could put a bar in there to help, but that's it. It's going to be a denture you take out. We got to get the lip support. Well, when conus came out, it really changed the game. It is the literal aha moment for me was this is the what else you got appliance for those situations where I need a flange, I need support, or I need it removable so the patient can clean it, or I need a lower cost appliance, but the patient really desires to have a fixed feel. In reality, this appliance, the conus denture concept, when it's seated on those implants, it feels like a fixed restoration to the patient. Now, we instruct them to take it out every night to clean it, but when it's in there, it's literally like a screwed in all on X. So that's good for the patient. It's a win for the patient, but it's a win for us in that, we can certainly shape that appliance like an all on X horseshoe with, convex underneath, no extra acrylic or anything, and same appliance. But if we need acrylic, if we need a flange, we can do it. It is a custom abutment type workflow, but it's all digitized. But it's a metal to metal. The housings are a gold alloy and the abutments are titanium. This thing came into being from an older concept, a stock appliance concept called Syncone. This was developed by the Ankylose Implant Company, and it was a stock abutment. They had two versions, a straight and an angled, and the Syncone caps. Now, this worked great when the implants could be placed exactly in the position that those two angles would support because the abutments, the four abutments, and you have to have four for a conus, they have to be parallel or very, very close to parallel. Now, if you're placing four implants and they've got to be exact, that's a challenge, and clearly. So what happened was that when Dentsply acquired Atlantis and they already had Ankylose, then they just merged. The engineers got together and said, Atlantis makes a really good custom crown and bridge abutment. Let's merge that with the Syncone and make a custom Syncone abutment, which is what they did. That's what you see on the bottom right. Now the angle doesn't matter because it can be customized in the manufacturing of that abutment and whatever angle that is. But the cool thing is they did not have to change the Syncone cap. It's the same exact cap. They just retrofitted the custom abutment to it. And so it really is a custom Syncone, but they gave it the fancy name called conus. That's really the only thing conus means, is custom Syncone. But it's picked up in the denture base like a locator, but it is a metal housing, not a nylon housing. So whatever the implant placement is, whatever the angle is, the lab is able to achieve the parallel that they need. Now, the first time I saw it, I thought, wow, titanium abutment and gold alloy cap, that doesn't sound good, right? Titanium's hard, gold's soft. The gold's going to wear away. This thing's going to get loose pretty quickly. Well, in reality, the way this thing's designed in what's called the conometric concept, it's like a beer glass or two beer glasses, right? It gets more retentive the further it goes down. So yes, it may wear, but again, it gets more retentive. These things actually get more retentive with age. I don't think you could make one wear out. So it's been exciting to have that kind of retention. Sometimes patients struggle with getting them out, but that's what we're looking for is good retention. And so two beer glasses stuck together is one thing, but 8 stuck together, connected by an appliance is a whole different thing. And so this is a really good frictional fit, good retention, but again, control, right? Flange or no flange, palate or no palate, right? We have all the options we need. There's just some things you have to be comfortable with and get familiar with as you're doing the conus cases. And the big one is what I call the magic millimeter, that space between that bottom millimeter of that metal housing and the acrylic has to remain free, right? Because that's where the swedging occurs, and that's where 98% of the retention comes from. So if we get acrylic in that space, then the cap won't swedge and the retention won't be there. So we've got to make sure that's there. The other thing with conus is the space, right? But as you can see, we can do it in 12 millimeters. I prefer to have 13, 14, 15, but it can certainly be done in 12. So space is not a problem. So we know the advantage of removal, right? 2 locators only cost X, right? And the lab only charges X for a locator denture. Easy care for the patient, no brainer, right? The other end of the spectrum, the fixed, we know the cost, right? Expensive, time, lots of appointments, lots of treatment. But when that's what we need to do, that's what we need to do. They both have their advantages, right? For sure. What conus does, or what the fixed removable is, that it pulls the best from both worlds, right? Being a removable appliance, we can take it out for what reasons we need to, but being a fixed appliance is that the patient, wears it all day like a fixed appliance, and it has that occlusal strength. So, the workflow looks like this. Flow charts, if you're an engineer type guy, flow charts work for you. I'm more apt to think in linear appointment things. So let's go through what this looks like. Right. So here's a case that has 6. Really don't need 6. 4 is more than enough. But for whatever reason, 6 was placed. As I mentioned earlier, I like to engage an implant or two when I'm taking records. So bite rim, for example, right? In this case, we want to do a bite rim. So we're going to engage a couple of those implants and screw that bite rim down and take that record, send that back to the lab, and the lab's going to do the setup. Now, that setup could be in wax on an articulator, or it could be in the computer world, right, to make it digital. And so the setup's done, and we haven't put any abutments or anything yet. All we've done, we know the implant placement, and we're doing a setup. So the setup then goes back to the dental office for the try-in. Again, if it's done in wax, and it's a traditional wax try-in. If it's done digitally, then it's a printed try-in. Either way works, but either way, wax or printed, I'm going to put a couple of cylinders in there and kind of bolt those down lightly to 2 of the implants, so we have a good stability. And the whole goal here is just to make sure the teeth are in the right spot. Right. We want the teeth in the right spot relative to where the implants are and where we need everything fitting. Once we have that done, then that data goes back to the lab, and the lab can then fabricate or order the conus abutments in the correct angle to fit within that space of the tooth. So it's a tooth down workflow, so that we make sure we don't run into problems space-wise by our attachments bumping into the denture teeth. So the abutments are ordered. They come back to the dental office for the 3rd appointment. And if the dentist and lab want to do a metal strengthener, right, that's a pretty common option, then the metal strengthener would come at this appointment as well. And what we like our dentist to do is go ahead and engage the metal housings, put the metal strengthener over that, and then pick up those housings in the metal strengthener with crown and bridge cement. And we always leave this proper space we need for acrylic. Right. If the tissue has changed at this appointment and we want to take a new impression record, then we simply pick up that metal framework and those housings in a new impression. This goes back to the lab, and the lab retrofits or jump fits over to a new mounting if there's a new impression, and then just sets the teeth using that index and processes it, and it's ready to go for delivery. And the lab can pick up the housings inside, or the dental office can do it, just like locators. So this is that workflow visualized, right? We've got an implant level impression and bite. We're going to do an aesthetic try-in with a printed try-in or wax try-in. Then we're going to verify that the abutments are in the right place with the framework and pick those up. And the final appointment is the delivery. And you can see the lab steps in between. So it literally can be done in 4 appointments. Now, there are cases, especially now with the new digitally printed dentures, that we don't do a framework, right? Because the new material is literally 3 times stronger than acrylic. So maybe we don't need a framework. And if we do so, then we just basically cut, a step out. We make it a 3 appointment. We don't have to do the frame try-in or the picking up of the housings. This is what that looks like, right? So here we are, right? And, the housings are engaged. And these white sleeves are what we use to protect that magic millimeter. Now, they aren't properly placed in this picture, so I could show you, what is, going on here, right? If those things are overplaced, right, pushed too far down, that millimeter of space is exposed. And the acrylic or the setup material, pickup material will fill that in and the caps won't have the same retention. So we have to be careful that we place these sleeves properly. We want it just under that bottom knurled row and covering up that last millimeter. Right. And then at that point, it becomes a simple pickup, which can be done chair side or it could be done in the lab. So in a case like this, it was first appointment, get the impressions, second appointment, get a bite and prove the aesthetic try-in, and third appointment, deliver. Again, same materials, chair side or Voco, and we pick them up. And like to send those 2 implants a little further back, and the posterior implants, but for this case, because of that, we decided to leave the palate in this denture, which is very helpful. Now, these things are super retentive. And, we've done this with locator cases as well, to give the patient an aid, maybe cut a notch in the buccal side of the denture, a place to put their thumbnail or fingernail to help give them something to grab to, pull it down or pull it up, push it up. Some labs have even made these little tools that they can use to grab that notch and pull it down. Same is true with this one. This one's going to have more retention than locators by far. And so you have to work with our patients. When we deliver these, we've always, sit there and make them put it in and out, 4, 5, 6 times to make sure they're comfortable with it. Another good thing to ask your labs to do is to do a sleep denture. This is a very cool thing to add to your treatment. It can be scanned. The original can be scanned and duplicated in the lab pretty easily, and the recesses cut out. And I wouldn't even put stuff in the holes. I just tell the dentist to put soft liner in it if you needed anything. But we hand this to the patient, say this is your sleep denture. So that does a couple of things. Number one, it's going to protect those abutments at night. But it also says if it's your sleep denture, that means the other one's got to come out, and which is what we want to do. Conus has so much retention, and because it's a concentric physics, right? So the harder they push or the longer they push, the more retention it could gain. If a patient keeps a conus denture in, longer than a couple of days, it's going to be more and more difficult to get it out. We've actually had offices call and say, the patient called and they said they can't get it out. What do I do? It's okay. We'll come over and help you, and we have to kind of pry it out of there. But if they don't take it out for a couple of weeks, it's going to be a challenge for them to get out. So give them the sleep denture, and that kind of says, okay, take this thing out every night, which gives you a chance to clean and inspect and all those other things. But also gives you the ability to get it out. So conus is also a great option for a partially edentulous case, right? So if these were 3 implants in this case, and there's a pretty big chunk of bone loss there, you're going to do a fixed restoration here. There's all kind of things you can do, certainly. Pink porcelain. If you've seen those restorations, right, they look pretty bad and they're very hard to clean. So conus gives us the ability to make a fixed yet removable, snap it on there, snap it off, but we could build a flange on it to help cover up that bone loss. So, conus and digital is great. This is a pretty massive case. This was a full restorative case, and obviously this guy's in a hot mess, and all this needs to come out. And so the initial plan was done. I did some intraoral scans with the intraoral scanner, and we took some cone beams And, we went in preliminary, took that data and started designing the restoration. The beautiful thing about digital is that if I can see the bone, I can see the vertical space, I can see where the teeth were, then digitally I can create anything, including a surgical guide to help the surgeon, with the bone reduction. All those things are in complete capacity in the digital workflow. And so we took that data and created the denture in the virtual world and then printed the dentures out, right? And so goes back to the doctor. And so the patient only had images made, right? We only scanned and took cone beams. So the next appointment, patient comes in, the doc's already got the dentures. And so the extractions occur, surgery's placed. And in this particular case, the tissue turned up being so bad that, we wanted to add some aid to help hold the provisionals in. So we put in these little ball hitch attachments while the patient healed. Those will come right back out when the final abutments go in. So the try-in's printed, right? And it goes out. We engage a couple of the implants and we put these try-ins in. And this material that InSequence is using is strong enough that the patient could wear this for a period of time. It's super strong tooth colored material, and the labs can even paint it pink if it's going to be longer. But the beautiful thing about this is it being a functional try-in, the patient could talk with it, eat with it, chew with it, right? And give you the data that you need to adjust occlusion or move midlines or anything like that. So once that's done and we've said, okay, the tooth position's good now, we've got our bite, that modified is temporary is scanned. That data is merged with the original. The abutments are designed to fit within that space, and the abutments are ordered, and the final restoration is created. In this particular case, it was a milled denture, right? So the denture base is milled, the teeth are milled, and they're bonded into the base, and then the retentive holes for the conus are cut. And we did this in the lab. So, we used our sleeves over the conus abutments and caps and, picked up those caps on a reline jig and bonded them in with a metal primer and delivered it. And, this was one of those cases where the patient said, oh man, is this going to take long? Well, not really. All we got to do is screw these things in and, snap these dentures on. And, in that wonderful shade that they always want these days. So the American Standard shade. So this was almost a completely digital workflow to get an implant case done using the conus system. So that's the what else you got, right? We all know that locators are reasonable, viable. It's probably 70, last I heard 72 to 74% of the edentulous implant cases are locator cases. So we know it's a very popular restoration. You'll continue to do those. The All-on-X has certainly grown in demand. You see it on TV everywhere and patients are asking about it. And again, if they say, I want teeth again, and they're willing to, pay the cost, they're willing to go through the surgeries and the time involved, then, the All-on-X is certainly a great option too. And then the conus is that other option for something in between. And I'll tell you, around the country, what I've seen is the price is pretty relevant to the treatment, right? Locator typically is at this level, All-on-4 is at this level, and conus treatment falls right in the middle. And that cost, meaning lab to denture to dentist, and then dentist to patient the same way. So you've got a good scale, and my theory of always having options. So it's easy to convert, right? You could call any of your locator patients and say, hey, are you ready for an upgrade? I know you wanted, fixed before, but it was too much. So, call those locator patients and say, hey, let me come back in. Let's talk to you about a new way of restoring. So get the tools you need, get the models, get the brochures to have these conversations and be able to offer these options. And so, your lab reps can help with that.